Hello, welcome to your online lecture for therapeutic ultrasound. This lecture will be broken up into a two-part series. The first part of the series will really just be talking about the scientific components to ultrasound, and then the second part of the series will be dedicated to the clinical application of therapeutic ultrasound. But before we can actually understand how to clinically apply it, we certainly have to figure out scientifically and physiologically what it is that ultrasound is purported to do within the human body. What we know about therapeutic ultrasound is that it's a deep penetrating agent, right? That produces changes in the tissue temperature that can either be thermal or non-thermal. So this is the first deep penetrating modality that we'll talk about in this course. The other deep penetrating modality that we don't talk about a whole bunch is a diathermy. The other modalities within the thermo and cryotherapy unit were superficial, either cold or heating modalities, right? And so this will be the first one that is capable of penetrating deep enough to some of our target tissues to cause physiological changes, right? So first stop is really just defining what therapeutic ultrasound is. In essence, what we could say is that therapeutic ultrasound is an inaudible modality that creates acoustic vibrations. And those acoustic vibrations are they're either high frequency, right? Or in some cases low frequency, but that low frequency is still relatively high. What we know about these acoustic vibrations, right? Or the bouncing back and forth between molecules is that they either can produce a thermal or a non-thermal physiological effect. And I think most of us in this class are aware of what ultrasound can do thermally, but I think one of the things that I've started to learn a lot more about as I dive deeper into the literature is about the non-thermal effects. And so I'm a big fan of therapeutic ultrasound for its non-thermal effects as well. We know about these ultrasound waves is that when they bounce off of one another or when they bounce off of the bone, they create molecular collision, which is what I was describing earlier, right? Molecules that bounce off of one another. And if they bounce off of one another fast enough, they create, guess what? Heat. And if there's a slow bounce, not enough movement, right, to cause heat, then they cause that thermal effect. And so these collisions cause a molecule displacement, and that's important and key. When the molecule displaces, guess what happens? The ultrasound wave can be transmitted to the physiological tissue of choice. So you can read the slide, but I think I've broken it down in such a way that it actually makes sense to us as clinicians. Progress through this lecture, it becomes important to continue to think about the modalities on a frequency spectrum, right? We looked at cryotherapy and thermotherapy and we saw where it fell on the frequency spectrum. And now we're looking at therapeutic ultrasound and also asking ourselves, where does it sit on the frequency spectrum when compared to the normal things that we do within our daily lives, right? So when we think about audible and our ability to hear sound, what we know is that the human ear is capable of detecting sound waves that range from about 16 to 20 kilohertz, right? So then you have to ask yourself, where on that spectrum does therapeutic ultrasound lie, right? And so if we look down here on this frequency timeline, for lack of better words, we'll see that the human ear, as we talked about, is really capable of kind of hearing sounds within this kind of frequency spectrum. And then you have your therapeutic ultrasound, which kind of ranges somewhere in between that 1 and 3 megahertz spectrum, right? So in other words, this is the frequency at which therapeutic ultrasound can actually be delivered, right? Now, there's therapeutic ultrasound, right? And then there's diagnostic ultrasound. And diagnostic ultrasound, as you can tell, falls on a different frequency. It's going to be closer to the audible sound than it is to the therapeutic ultrasound. And this is important, right? It's a key distinct feature because what we know about diagnostic ultrasound, the ultrasound that we would use to look at musculoskeletal injuries, the ultrasound that we might actually use to look at a baby in utero, right, is that it's not really capable of producing thermal effects. And that's key, right? We don't want to put an ultrasound on a pregnant woman and increase heat within the uterus, right? And so those are key distinct features as you're trying to figure out, well, what is the major difference between therapeutic ultrasound and diagnostic ultrasound? It's really about where they lie on that frequency spectrum and how many waves they're able to produce, right? Okay, so one hard concept for students to grasp a lot when we get into the ultrasound segment is depth of penetration. I've already told you that ultrasound is capable of penetrating deeper, a lot deeper than most of the modalities that we've talked about thus far. But then we have to think about when we're setting our ultrasound, which of the settings is going to tell us how deep that ultrasound is going to penetrate, right? So look and track with me here, guys. We have lower frequency ultrasound settings and we have higher frequency ultrasound settings. And all of you are in the clinical setting now, hopefully, and all of you have probably at least done one ultrasound in your career. So when I'm saying lower frequency, I'm talking about that 1 megahertz treatment. And then when I'm saying high frequency, I'm referring to that 3 megahertz treatment, right? So what we know about therapeutic ultrasound is this. Our lower frequency treatments, our 1 megahertz treatments are capable of penetrating deeper than our higher frequency treatments, those 3 megahertz treatments. Our higher frequency treatments are going to be used more for superficial absorption, for targeting the superficial tissues. If we want to dive deeper, if we want to hit the piriformis, if we want to hit the soleus, then we need to be using a 1 megahertz treatment to ensure that there's enough molecular vibration to drive those ultrasound waves down to the target tissue. More to come on this area in just a second. Okay, so in therapeutic ultrasound, we really have 2 different waveforms, and these waveforms become extremely important to understand, right? Because it's the way in which the molecules are displaced. And that's important because remember, molecular displacement leads to what? The ultrasound waves being able to penetrate and then to be absorbed by the deeper layers. So when we think about a longitudinal wave, the way that I think about this is a person dangling from the end of a bungee cord as an example of a longitudinal wave. Longitudinal waves in general will result in like elongation and contraction. So at some point in time when that person jumps off the bungee cord, it's elongated. And then as they reach the end of the bungee cord, what happens? They get pushed back up to the top of the bungee cord, right? So there's periods of elongation and there's periods of contraction, right? And that displacement is always in the direction of the ultrasound wave or wave propagation, right? And that's a good thing. That's what we want to happen. When we create longitudinal waves, this is what allows that ultrasound wave to be transmitted to the target tissues. What we know about longitudinal waves is that they travel best in liquids and solids. So they're going to travel well through blood. They're going to travel well through soft tissue. And we need that to happen, right? We need a wave that doesn't get repelled or reflected by the tissues or the liquids in our body, right? Because if they do, then they can't travel down to the target tissue. So we want longitudinal waves. And most often with most ultrasound treatments, we will produce longitudinal waves. The type of wave that we actually don't want is called a transverse wave. We know about transverse waves is that these are displaced perpendicular to the direction of energy. So in essence, it's going to slow down the transmission. It's going to reduce the amount of penetration and absorption of our ultrasonic energy because in reality, it is being displaced perpendicular, which means it's reducing the amount of energy that we have left over to transmit those ultrasonic waves. What we know about transverse waves most often is that transverse waves pretty much can only travel through solids, so bone. So let me say it this way. Transverse waves cannot pass through fluids. Are we tracking there? In other words, if they can't pass through fluids, we can't pass through blood, they may not be able to get through some of our soft tissue that's filled with a lot of water, then our ultrasound treatment is not going to be effective. What we do know is the area that we see most transverse waves actually occurring in the body are when ultrasound strikes bone. So here's my caveat to you. There are going to be times where we have to ultrasound an area of the body that is extremely bony. And I can think of 3 prominent areas in the body right now just sitting here lecturing. The first one is for medial tibial stress syndrome as we ultrasound that tibialis posterior and we get really close to the tibia, right? If that ultrasound head stays on the tibia, it's going to create transverse waves, and that is going to do what to our treatment? It's going to reduce our treatment effect. So we have to make sure we're staying closer to the tibialis posterior, right? And further away from the medial tibia. The other area that we're most likely to see transverse waves is ankle injury. So when we're ultrasounding very close to the medial or lateral malleolus, and then last but not least, elbow injuries, right? So what am I saying to you? There are going to be times in an ultrasound treatment where we get transverse waves because we just can't help but to ultrasound over part of the bone, right? But the more that we can stay on the soft tissue, the more that we create longitudinal waves, the more ultrasonic energy that is going to be, guess what? Transferred to the rest of the body. Now, on this image, you see these areas of what are called compression and rarefaction. In a longitudinal wave, we want this to happen, right? Remember, it's that bungee cord kind of effect. What we know about the area of compression is that this is the region of like really high particle density. And then we have rarefaction where we kind of have a loosening up or a lengthening of that cord. And that's an area of low particle density. But we want that to happen. We want compression. We want rarefaction because just imagine, right? If you continue to stretch, right, and then compress, it's creating what? More pressure to push that ultrasound wave down. So that compression and rarefaction becomes important. And this happens in a longitudinal wave in this way. But can you see how in a transverse wave that changes, right? And so now what we're doing is we're creating resistance for that ultrasound wave to transfer through, right? There's resistance here as opposed to facilitating that ultrasound wave through the rest of the body. Okay, so there are some concepts that we probably need to talk about before we really move forward to actually talking about the clinical utility of ultrasound. We have the concepts of impedance, attenuation, reflection, and absorption, right? And most of these are terms that hopefully all of you have heard at some point in time or another. But this idea of impedance represents the amount of ultrasound energy that's reflected at the tissue interface, right? So let me say that again. The amount of ultrasound energy that is not going to get delivered to the target tissue. So when we think about impedance, we have to think about what things would highly impede an ultrasound treatment. I'm going to let you sit on that. Maybe pause the video and think about it. What things in the patient ultrasound treatment world would impede the ultrasound's ability to deliver the maximum energy intensity? Did you say ultrasounding near a bone because it's going to cause transverse waves? Did you say hairy patients? Did you say not cleaning your patient's skin before applying therapeutic ultrasound? If you said any of those things and you're thinking, okay, these are things that are going to increase impedance within our ultrasound treatment. So you're going to do whatever you can as a clinician to reduce the amount of impedance that will be experienced during an ultrasound treatment, right? So then we have attenuation, which essentially is this decrease in energy intensity or signal strength, for lack of better words, or ultrasonic energy, which typically happens as a result of scattering of the ultrasonic energy or divergence of the ultrasonic energy through the tissues. In other words, what I'm saying is, as we move from tissue layer to tissue layer to tissue layer, either that energy is going to be absorbed, it's going to get scattered, it's going to diverge. And so that process of attenuation is this process of decreasing in ultrasonic energy as we progress from one tissue layer to another. And we're going to come back to this concept of attenuating in just a second. But essentially, it represents the amount of energy left over as we move from one layer to another. Okay. This other concept of reflection, if we were to define reflection, this occurs when a wave can't pass through to the next density layer. So in other words, we have our ultrasound wave traveling to another tissue layer, and before it can even get absorbed by that tissue layer, it gets reflected back towards the top. What am I saying to you guys? If an ultrasonic wave can't pass to the next density, it has to go somewhere. So typically that wave is going to strike that object and it's going to reverse its direction away from the material, which means our target tissue isn't going to get that ultrasonic energy. And that may be okay if our goal is to heat the superficial layers. But reflection is terrible if the goal is to reach those deeper tissue areas. So you have to ask yourself the goal of the treatment, right? Now, what we know about reflection is that it can be complete or it can be partial. So let me give you two examples of a complete reflection. One would be turning on the ultrasound machine and just allowing that ultrasound head to sit up in the air. Waves are going to bounce off of the ultrasound head and reflect back to the ultrasound head. That's probably in its simplest form, right? In terms of partial reflection, that's going to happen when we're typically ultrasounding over a bony area that exposes the ultrasound head. So most often that's going to be like the olecranon process, the acromion, right? And or any of the lateral or medial malleoli. Because what we know about that is that the ultrasound head isn't making 100% contact with the patient. It's making some contact with the external environment. So we're going to get partial reflection. If I define it Cosby terms, it would be energy that is unable to be absorbed. And that can be a good thing or a bad thing, again, depending on the goal of the treatment. And then finally, the ultimate goal of ultrasound is absorption. When you think about absorption, this is what occurs when the tissue collects or absorbs the wave's energy. And then not only that, but it changes it to a kinetic type of energy. Most often that kinetic energy is going to produce heat, right? We get molecular vibration that occurs. That molecular vibration causes a thermal effect. And if that's the goal of the treatment, then yay, kudos. But sometimes in ultrasound, that kinetic energy might not be transmitted or transformed, into heat. It might actually be transformed into things that cause healing, fibroblastic repair. And we'll talk about that when we get to non-thermal. But the ultimate goal, you guys, for therapeutic ultrasound is absorption. We just have to get through tissue impedance, and we have to figure out how much is left after some of the energy has been attenuated. And I said we come back to attenuation, and here we are again, right? Defined as the decrease in energy intensity, most often due to, right? It's absorbed, which is what we want. It's dispersed or scattered, and in some cases, right, reflected or refracted. Now, what law of thermal energy is this? So let me say it this way. Energy absorbed or reflected or dispersed or scattered by another layer cannot be absorbed by another. That is which law? It is the law of Grothus-Draper. So do you see how these laws are carrying forward, right? So we have to do everything we can to minimize the amount of reflection, dispersion, and scattering. Absorption is just going to happen as we progress from layer to layer, but we want enough energy left over for the final layer so that we can actually see these therapeutic responses that we want to occur in the clinical setting. Okay, you guys, I think this is a very intuitive concept, penetration versus absorption. So if we were to define penetration, the ultrasound energy that's able to pass from one layer to another, right? And then absorption is energy that's stored by a layer and is transformed into kinetic energy, right? So we have those two different concepts. What we know about the two is that there's this inverse relationship. So just think about it this way. The depth of penetration of ultrasonic energy in the tissues is going to be inversely related to its output frequency. So remember I said early on, a 3 megahertz treatment is going to be absorbed by the superficial layers, and a 1 megahertz treatment is going to be absorbed by those deep tissues, right? We're coming back to that concept. So the lower the output frequency is, the deeper the penetration will be in the actual tissues, right? Now, let's think about this a little bit differently, right? I want to give you some numbers, but then we'll talk about it again. But a 1 megahertz treatment, that deep treatment, is capable of penetrating about 5 centimeters. And then a 3 megahertz treatment is typically capable of penetrating about 3 centimeters in terms of its depth. I hope that makes sense to you all. If not, email me and we can discuss it. What we know about the high frequencies, those 3 megahertz treatments, ultrasounds, is that because of the increase in intensity and frequency, that energy is just rapidly absorbed by the superficial tissues, right? And so because of the high frequency, those superficial tissues just eat it up, whereas a lower frequency treatment will bypass the superficial tissues and get absorbed by the deeper tissues. Now, what we also know about therapeutic treatments with ultrasound is that tissues high in water content, decrease absorption. So adipose tissue is not our friend. It's going to absorb. It's an absorber of almost any energy that we can talk about in this class. And then tissues high in protein can increase absorption, which is what we want. We want our skeletal tissues to absorb that ultrasonic energy, but we have to get it there. We have to get it past adipose tissue. We have to get it past any impedance that we have within our particular patients, right? So penetration and absorption, we have to think about that from a frequency standpoint. If it's a high frequency treatment, the superficial tissues are going to absorb it. If it's a low frequency treatment, then those superficial tissues or those deeper tissues are going to absorb it a lot more. So let's take a look at this image here. This is not in your textbook, but I think it's an important concept as you begin to work with patients, because a lot of novice clinicians will make this mistake. This is what we would call a T wave or a standing wave. So what we know about bone tissue interface is that a massive amount of reflection occurs at the bone ultrasound interface. So this is why this is important for you to understand why you have to keep the sound wave moving, because if not, what we see is that you can increase tissue temperatures. I'm going to go here, increase tissue temperatures in our bony patients relatively quickly and cause a burn. So if your patient is complaining that they feel the ultrasound, that it's burning, you need to either move that ultrasound head quicker because you're getting a lot of reflection or a lot of T waves and you're going to burn that tissue. Now, can we cause degradation of tissue? Certainly. We're certainly capable of heating the tissues up to a high enough temperature to cause degradation. But with ultrasound, because there's movement, right? We typically don't see that happening. However, I have seen clinicians just put an ultrasound head on the patient and keep it there. And in my mind, I just want to go over there and start moving their hand for them. The reason we want to move the ultrasound is because we're going to have some reflection. Regardless of how great the variables are when we start our treatment, we're going to have some reflection. We're going to have waves that scatter. We're going to have waves that diverge. We're going to have waves that reflect. But when we move that ultrasound head, we reduce, look at this, we reduce the reality that the waves might reflect off of one another and collide and cause an increase in energy, right? I hope that I'm not scaring you away from using ultrasound. What I'm saying is make sure you keep the ultrasound head going. Okay, so ultrasound at tissue interfaces. What we know about ultrasound is that some of that energy is going to scatter due to reflection and refraction, but then you also get acoustical impedance. And that has to do with the tissue density and the ultrasound wave changing its speed as it moves from one tissue density to another, right? And that's going to help us determine what's reflected versus what's transmitted. Also, the change from tissue to tissue, right? That change is also going to slow down the speed at which the ultrasound wave travels, the direction in which the ultrasound wave travels. So these are all things to kind of keep in mind as you're working with ultrasound. We know about ultrasound is that most of the energy will be transmitted as long as we reduce impedance. And we can do that by cleaning our patient's skin. We can do that by having hairy patients shave. We can do that by maybe sometimes heating the treatment area, especially in our larger individuals. There's a lot of different ways to reduce the amount of impedance. And so what we know about tissue densities and acoustic impedance is that the larger the difference in acoustic impedance, the more energy that's going to be reflected. So the more that we can reduce that impedance, the more that we can improve our treatment area, the more likely we are to see the clinical benefit or utility of using therapeutic ultrasound. Now we have reflection versus transmission. I've kind of already alluded to this, but if we just put the transducer head in the air, you will have 100% reflection, right? Through fat, what we know is that most of it's transmitted, but the rate at which it's going to be transmitted is sometimes slower or met with a little bit of At muscle fat interfaces, did you hear that? So muscle fat interfaces, We get reflected waves and refracted waves, but most often what we get is an absorption that occurs once we hit the muscular tissue. And then soft tissue bone interfaces, most of it's going to be reflected and cause those hot spots like I said. So the ideal would be, once we've reduced acoustic impedance, the ideal would be trying to get to that muscle fat interface so that we can have our energy absorbed by that target treatment. Okay, so is this interesting to you guys? Tissue such as bone, cartilage, and tendon absorb much more ultrasonic energy than muscle, fat, and blood. What does that mean, you guys? If we are ultrasounding over bone, cartilage, and tendon, it's going to absorb most of our energy, and then we won't have any energy left over to deliver to our target tissue, which most often is going to be muscle. Now, if your target tissue is the tendon, which most often in a patellar tendonitis and Achilles tendinopathy totally is, then we're in good shape, because what do we know about ultrasound? Tendons love to absorb, right? Now, cartilaginous structures are very hard to kind of get at, right? So if we're thinking like the meniscus in the knee, for example, first we have to get through the fat pad that exists, right? On the infrapatellar fat pad that exists and sits between that meniscus and the epidermis, right? But certainly we can see that, okay, if it's a tendinous structure, ultrasound is a great tool to use, because a lot of that ultrasonic energy is going to be absorbed by the tendon. If our goal is to get to the muscular layer and we're doing that through a bone or we're doing that through a tendon, just note that a lot of your ultrasonic energy is going to be absorbed by those tissue structures, right? So we just have to be thoughtful about where we are ultrasounding. I am not saying that ultrasound is not effective for muscle. I am not saying that at all. I'm saying that if you are trying to ultrasound a muscle that lives deep to a tendon, it may be very hard to get energy absorption for the muscle. It's very rare in the human body. However, most muscles are just covered by the dermis and epidermis. So in that case, we just need to make sure we clean our patients relatively well. Okay, let's talk anatomy of ultrasound. In general, there's an ultrasound generator, or the box, right? And that ultrasound generator has an electrical output. It's going to be able or capable of producing some type of mechanical vibration, which we'll talk about with its crystal. It should be capable of creating a sound wave, and that sound wave, once it's delivered, should be able to be absorbed in the tissue. Again, this part is all based on what we do to reduce acoustic impedance, right? And to set our patient up for success in terms of delivery of the ultrasound. Now, the therapeutic ultrasound generator control box, we have the timer, which is going to be our treatment time. We have how much power that machine is capable of delivering over time. That's going to be based on the manufacturer settings. So choose wisely when you're choosing a device. Me personally, I want to make sure that I have a device that is capable of outputting to its highest intensity. So I'll usually choose a device with higher intensity, because then it's capable of treating more musculoskeletal structures. Okay, you have a device that typically has intensity control, right? Most often that's going to be expressed in watts per centimeter squared. And then you want a device that has duty cycles. So we've seen it a lot of times as 10%, 20%, 50%, and then 100% or continuous, right? The more options you have on your device, the better. So as you get ready to plan to buy therapeutic ultrasound machines, you want a device that gives you the option to have duty cycles. If you go down to our Point Loma clinic, I believe we have a device that doesn't give you an option. It's just continuous, 100%. And so we'll talk about why that's not good clinically, because it won't allow us to do non-thermal treatments. Well, it will. You'll just have to set it a little bit differently. And so then again, there's the continuous versus pulse, which is the same thing as the duty cycle. And then we want a device that has an automatic shutoff. And I don't even think nowadays on the market they sell them, but if they don't, you want one, right? Because if that transducer head overheats, think about this. When would a transducer head overheat? If we're getting lots of waves that are reflecting, right, back and forth, if we're ultrasounding over a highly bony area, then that ultrasound head may overheat. And we want a device that shuts off, because it's going to protect our patients, and that's exactly what we want. So as we look at the actual transducer itself, right, because the transducer is just as important as the output box, right, that it lives in. You can purchase multiple types of transducer heads. Normally, I wouldn't cover this in this lecture, but why not? Usually you'll get it in the lab, and I'm going to assume you're going to get it there, but I will cover it here too. So if you want to skip through this part, go for it. But I can tell you that this is an important aspect to therapeutic ultrasound application. The transducer or the applicator is the second most important part to selecting an ultrasound unit, right? You have the box, which we just talked about, and then we have the transducer head. Now, the ideal would be that we would purchase multiple sizes of ultrasound heads. But if you have to choose between a small and a large, most often clinicians choose the larger ultrasound head because it's capable of treating larger, does that make sense, treatment areas. But the ideal would be that you would get ultrasound heads in various sizes. A small ultrasound head would be good if we're over a bone tissue interface because it would ensure that we're living over the actual tissue and not over the bone, right? And so most units, it's not interchangeable, but your textbook says this, but I'm telling you, you certainly can swap them out by plugging them in. So the newer units do allow for you to change the size of the actual head itself. Now, the most important part of the ultrasound head is the piezoelectric crystal. Most often that is going to be made of quartz, lead zirconate, barium titanate, and nickel cobalt. So one of those, they're all grade quality, all approved by the FDA. You can choose which one works best for you. There isn't any research to suggest that one is a superior ultrasound head than another, but you need to know that the ultrasound head does house a crystal, right? The type of crystal, not as important as the fact that it actually houses a crystal. So as we progress, why is that crystal hugely important? What we know about the crystal is the key to ultrasound. The crystal is what converts that electrical energy to sound energy, right? This crystal within the ultrasound head is capable of kind of flattening and then widening and then flattening and then widening. What we know about this is that it doing that causes an electrical energy, and then that electrical energy is going to change through to sound energy through mechanical deformation or that flattening or the widening of the crystal itself. So let's talk about principles and definitions. The piezoelectric effect. Now, we can look at an ultrasound head and we can say, okay, this is an ultrasound head when the device is off, okay? Then we push the on button. We're not talking about starting the ultrasound treatment. We're just turning on the device. We're turning on the box, pushing the power button on the back of the actual unit. What we know about the piezoelectric effect is this. When an alternating current is passed through a crystal, it will expand or compress and compress. Does that make sense? The direct effect, here it is, piezoelectric direct effect. An electrical voltage is generated and then the crystal expands and compresses. So we have an alternating current. We turn on the machine. So it's off. We turn on the machine, right? And turning on the machine will create an alternating current. That alternating current is going to cause that crystal, do you see it, to expand and then to compress. So far, so good. So we have essentially this voltage being generated. Does that make sense? Starting here in a neutral position, turn that device on, alternating current causes compression, and then we have voltage being generated. That is the direct effect. Here, we have a device that's off. We turn on that device, it begins, and we're going to start our treatment. That's going to generate an alternating current that's going to cause compression of the crystal. That crystal, now, let's take a look at this, and we're going to look at something called the indirect or reverse effect. As that voltage is being generated, as that alternating current reverses its polarity, the crystal expands and contracts and produces that ultrasound wave, right? So I'm going to go back. If we look here, the voltage is applied, that crystal is compressed. As that crystal expands again, you will note a change in the polarity, right? It's that change in polarity that allows for an ultrasound wave to be produced and delivered to the tissue. Now, on your exam, you're going to get a question about which effect causes or generates an ultrasonic wave. It is this effect here. It's the reverse piezoelectric effect. When the voltage is applied, right, the crystal compresses, and when it expands again, that polarity is reversed, and it's the reversal of the polarity that causes the generation of an ultrasound. Now, we have to look at other concepts within the ultrasound anatomy. The first thing is the effective radiating area, or the ERA. The effective radiating area is, as the name implies, what area of the ultrasound head is actually producing ultrasonic waves. There is a very terrible assumption that's made. We purchase an ultrasound head that's this large, and we assume that the entire head is capable of generating ultrasonic energy, and that is false, okay? What we know about the effective radiating area is that it is that portion of the surface of the transducer head that actually produces the sound wave. So you're going to have to look for the ERA on the actual device itself. The device itself will tell you which part of or how much of the actual ultrasonic head is actually, let me do a different color, transmitting ultrasonic energy. And you can see that most often that effective radiating area is much smaller than the actual ultrasound head itself. Does that make sense, you guys? So why is that important? Because if we make the assumption that our entire head is emitting ultrasonic energy, then that's a terrible assumption to make, because we'll treat a larger treatment area than the ultrasound head is capable of treating. Are you tracking with me here? In other words, always make the assumption that less of the ultrasound head is emitting ultrasonic energy, so that you'll treat or break up your segments into smaller pieces to ensure that each piece is getting ultrasonic energy and is able to be treated the way that you need it to be treated. Are you tracking there? So you can look at effective radiating area on a device. So when you're searching for an ultrasound machine and you're looking to buy one, you just look, okay, first things first, I need to know, does it have multiple cycles, 10%, 20%, 30%, 50%? Does it give me the option to move from a thermal ultrasound to a non-thermal ultrasound? That's one question you want to ask, right? You want to look at its intensity. How high is it capable of going? We need to know that. We want a device that has a high intensity. The third thing we want to look at is effective radiating area. I'm buying a large ultrasound head, but is that large ultrasound head going to transmit energy? Is all of it? Is some of it? Is 75% of it? You want to know what you're getting before you actually buy the device. Okay? So, frequency of the therapeutic ultrasound treatment. What we know about ultrasound treatment at this point, I think I'm being a little bit redundant, is that it can range from about 0.75. I would even just say 1. I have yet to see a machine that has said 0.75 megahertz to 3, right? And we know that the 1 is going to be the deeper penetrating, and the 3 is going to be the most superficial, right? In terms of depth of penetration. Okay, so I hope this is helpful just as a... Okay, so here we go. You guys all said, Dr. Cosby, we have lab, but I still want to know more. So here we go. I'm going to be a little redundant because I feel like this is probably one of the most important pieces to this particular part of the lecture. So we have frequencies of 1 megahertz, 2 megahertz, and 3 megahertz. Now, my least favorite frequency is 2 megahertz. So if you choose it on an exam, I want you to give me a good reason that you chose it, okay? Because it's the middle of the ground and it doesn't allow you to make a good clinical decision, okay? So what we know about ultrasound is higher frequencies get absorbed quicker, so they are superficial tissue heaters, right? So that 3 megahertz, as you can see, is going to penetrate up to 2 centimeters, yes? That 2 megahertz treatment, like I said, is in the middle of the ground, so it's capable of penetrating about 1 to 2 centimeters. And then the ideal would be a 1 megahertz treatment if we're talking about deep tissues. Now, we're all get excited when we're like, oh, it's capable of penetrating deep tissues. How many deep tissue structures do we actually have in the body? I can think of soleus. I can think of piriformis. I'm pretty sure I could think of a few others, but there aren't very many, right, guys? So what type of treatment should we most often be doing in the clinical setting? Good, a high frequency treatment, right? Because the goal is superficial treatment, right? I'm not to say that it isn't to say that we shouldn't use a 1 megahertz. We need to make sure if we're using a 1 megahertz that we're actually wanting to heat a deep tissue, right? Okay, so that 1 megahertz is going to penetrate about 3 to 5 centimeters. And then I say precautions. Precautions with 3 megahertz. What are they? The biggest precaution is because it's a high frequency and because all of that energy is being absorbed by that superficial tissue layer, is that we have the risk to do what to the tissue? To overheat it, right? Which is okay as long as we don't overheat it too much to cause tissue degradation or denaturation, right? Very rare, doesn't happen very often, so don't overthink it. All right. Next, we have the ultrasound beam. And so as we're looking at this ultrasound beam, I'm encouraging you to think about the depth of penetration. So when we think about the ultrasound beam, the depth of penetration is frequency dependent, right? We've said this multiple times today. The depth of penetration, if it's 1 megahertz, that's going to be deeper. If it's 3 megahertz, it's going to be superficial. Now, I'm going to hammer you guys on this because every year I have at least a student get it wrong. The intensity of the treatment does not determine the depth of penetration. The depth of penetration is pre-selected the moment you select the frequency of the treatment. Now, you can crank your intensity up to 2.0 watts per centimeter squared. You could turn it all the way down to 0.5 watts per centimeter squared. The intensity does not in any way impact the depth of penetration of your treatment. The only thing that does is the frequency. Are we clear on that? I hope so. If not, you guys yell at me via email and we can discuss it. Okay? All right. What we know about the ultrasound beam in general, and this is probably going deeper than you guys want to know, but I happen to think it's an important concept because you have to understand where ultrasonic energy is coming from, right? We have to get this good understanding of what ultrasonic energy actually looks like itself. So what we know about ultrasound energy is that it concentrates energy in a limited area, right? We know about larger head treatment. So those that have larger heads on them, devices that have larger heads, is that it's going to be more columnated. In other words, it's going to be more like a beam. It's going to be more of a focused treatment. So larger heads lead to more focused treatments. Think about this. Think about a water hose. If I have a water hose with a big head on it and I turn up the water as high as it can go, what's going to happen, guys? It's just going to drop down into a beam, right? Think of that as the large head treatment. With a smaller head, if I blast that water, what's going to happen to it? It's going to diverge everywhere. So a smaller head, believe it or not, is going to be more divergent and will cover more of a treatment area. So it's a less focused treatment. And I know that's a hard concept to kind of wrap our heads around, but larger heads typically tend to be more columnated. Smaller heads tend to be more divergent. And the way I get people or students to think about this is to really, truly think about water hose and pressure. Okay, so I hope that's helpful for you all. So let's talk ultrasound beam, and then let's talk the different kind of anatomical structures in the actual beam itself. So the area closest to the transducer head, the point of the pressure of the sound field is going to be most non-uniform, okay? And that's due to the way or the manner in which the waves are generated, right? And the differences in acoustic pressure between the actual transducer head and the epidermal layer of the patient, right? So we can think of this as the near field. It's the portion of the ultrasound beam that is going to be used for therapeutic purposes. So it's the part of the beam that's going to cause our therapeutic response. The pressure variations occur because the transducer head acts as if it were formed by many transducers. And so it's going to produce lots of different sound waves, right? So it's the area closest to the transducer head, the near field. It's the area in which we see most of the therapeutic purposes occurring, or the most of the ultrasound waves occurring. Okay, the point of maximum acoustic intensity. Try saying that twice. This is where the waves are indistinguishable and arrive simultaneously. So you can see that kind of here in this image. And then last but not least, we get the far field where the energy is more evenly distributed. And you can see here the beam is becoming a little bit more divergent in nature. But it's this near field where we see most of the ultrasonic energy being produced. And it makes sense, right? We can see more of the waves sitting here. So it's the point of intensity, which is here. And then we have the near field. So it's these 2 points where we see most of the ultrasonic energy being produced and getting ready to travel down and get absorbed by the tissues. This image here, the greatest intensity in the beam. Got it? Okay. Intensity. When we talk about intensity, it's the rate at which energy is delivered per unit area. It has nothing to do with depth of penetration. So I'll say that again. There are really 2 types of intensities that we have to think about. The first one is spatial peak intensity, which is the greatest intensity within the beam. Okay. Greatest intensity in the beam. Let's go back. Then we go spatial average intensity. And this is what we typically report in the clinical setting. It's the average intensity in the beam. So it represents the peaks, the lows, the in-betweens. It's going to be the average intensity within the beam. This is what we typically report, or I guess, what am I thinking? Right in our clinical notes. There you go. Okay. For some reason, this software is throwing things off a little bit. So I'm going to draw in a line here. That's where that pink line should have been. The spatial average intensity essentially represents the total watts, right? Divided by the effective radiating area. Where do we know that from? The amount of the ultrasound head that's doing what? Is generating. Good, you got it. Energy. Okay. Next, we have to look at this thing called the beam non-uniformity ratio. The beam non-uniformity ratio is extremely important because what we know about the ultrasonic output is that it consists of peaks and valleys. It consists of high and low energy. And there are imperfections within every ultrasonic crystal, right? Just think when your fiance, your hubby, your significant other buys you a wedding ring, right? Or a band. What do we know about that crystal? It's not perfect. Even if you get VVVVS, right? It's still not perfect. It's flawed. The same thing happens with an ultrasonic crystal. It's flawed as well, which means since it's not a perfect crystal, we're going to have areas where there are high ultrasonic intensities and low ultrasonic intensities, right? So the BNR describes that variation between the peaks, between the spatial intensity and between the valleys or the lows, right? And we can kind of think of this BNR or this beam non-uniformity ratio as the variability of intensity within an ultrasound beam, right? Now, it's due to the imperfections in the crystal. And so what we have to think about is what's an optimal beam non-uniformity ratio, okay? The ideal would be 1:1. What does that mean when I say 1:1? Anybody? It's one that has no peaks or valleys. It's completely consistent, right? But that's just impossible. We're going to have imperfect crystals, so there's no way the ultrasound treatment is going to stay consistent the entire time we're delivering the ultrasound treatment, right? So the ideal would be either a 2:1, anything between a 2:1 or a 6:1, right? So if we think about that, if we take this example that I'm going to give you right here. So if the BNR indicated is, let's say, a 2:1, okay, we'll go with that example, a 2:1. What we're saying with this is if we select an output intensity of, let's go with 1.0 watts per centimeter squared. So this is what we put on our ultrasound treatment. What we know about this is the maximum intensity that could occur in that treatment is going to be 2 times 1. Does that make sense? Or 2 watts per centimeter squared. That's the highest it could spike, right? And we're okay with that. But now let's think if we had an 8-to-1 BNR and we were using a 1.0 watts per centimeter squared. That means at some point in time in the treatment, because that crystal isn't perfect, we could have an 8 watts per centimeter squared treatment, right? And that's too variable. We could actually cause hot spots and hurt our patient here. So the ideal would be getting as close to 1-to-1 as we can, which would be a 2-to-1. But most devices that I've seen have been 3-to-1, and that's totally okay. It just means on average, this is what we're going to deliver, right? But we certainly could have peaks of it could peak up to 2 watts per centimeter squared. If we had a 3-to-1 BNR ratio, then it could peak up to 3 watts per centimeter squared during that treatment. I need you guys to know that what you're reporting is an average. It isn't the actual, okay? Now, the great thing about the FDA and most therapeutic modalities is that they're governed by the FDA, which is why we have to get them assessed or calibrated every year. And what we know is that there are no machines on the market that can be sold that have a BNR ratio of 8-to-1. The highest would be a 6-to-1. If you find one, let me know. So the beam non-uniformity ratio, the lower the BNR, the more even the intensity, right? So the less spikes that we'll see in a treatment. Manufacturers must include the BNR on their generators. What I do know is that lower BNR devices cost more, right? Because they're more consistent and they probably have a better crystal, so they're going to cost more, right? Better generators have low BNR, thus provide a more even intensity throughout the field and throughout the entire treatment. So we can kind of see here, this is a consistent treatment that probably has a 2-to-1 BNR, and then we can see this 8-to-1 where there's been this kind of spike in the treatment. You see it, those little hot spots that are occurring. So again, if we're thinking about a unit and we want to purchase one, need to know how much intensity that device can deliver. We want one that gives us options for our thermal and non-thermal treatments. Yes, we want to be able to select a head that has a really good, large, effective radiating area, potentially. We also want to make sure that we have a relatively low beam non-uniformity. Okay, so transducer. We've talked about effective radiating area, and then I just want to say this: choose an area that is the appropriate size. So essentially what they recommend is you shouldn't be ultrasounding an area that is any larger than 1.5 to 2 times the effective radiating area. So it becomes important to know what that effective radiating area is. With larger muscles, you're just going to have to chunk that. You're going to have to break up your treatment. You might do 3 treatments for a quad or 4 treatments for a quad. The speed of rotation will vary the heat. So what we know about ultrasound treatments is the slower your rotation or movement of the transducer head, the more heat that is going to be produced, and the faster, the less heat. Now, you shouldn't be going so fast as to not allow the ultrasound waves time to transmit, right? But the way I think about it is row, row, row your boat gently down the stream. Merrily, 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 life is but a dream, I think. Okay, so you get my point. You sing to row, row, row your boat, and you will know that you are going at the right speed. So what's the ideal transducer head? Largest size transducer, best effective radiating area, and the ideal would be a low BNR, because this is going to create the most consistent treatment, and guess what? Allow for what? A larger treatment area to be treated. Thank you so much for listening to this. I know it's a lot, but if you get this, then the next lecture is relatively easy.